My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you're interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode. This is our third in a series of episodes called M&M, or Myths and Misconceptions about Osteopathic Medicine. Today we will tackle the sentiment that osteopathic medicine is quote-unquote voodoo. Typically, this idea is based on the fact that the scientific evidence behind the modality is limited. I want to start by sharing with our listeners that a large percentage of what we do in, quote, conventional medical care on a daily basis does not have scientific foundation. That having been said, there is no question that in Western medicine, what we strive for is evidence to support our practice. This includes many types of studies ranging from bench work in the lab to clinical research on patients. To tackle the question of is there evidence to support osteopathic manipulative therapy, or OMT, we will speak with Jordan Keys, DO, Professor of OMT at NYIT-COM, and Dr. Kim Wolf, DO, Director of Pediatric Osteopathic Manipulative Medicine at Touro, California. They will speak about the importance of showing the validity of osteopathic manipulation in scientific study, and will discuss the many other doctors around the world that share their passion. They will talk to us about a conference that they started this year called CORK, or the Conference on Osteopathic Research and Knowledge, where they bring together scientists from around the world to share their insight into evidence-based care of osteopathic manipulative therapy. We know you will enjoy this episode. I'm really excited to have both of you on today. Can you start by just introducing yourselves for us?
So I'm Jordan Keys. I am an osteopathic physician. I am family medicine and neuromusculoskeletal medicine boarded, and I'm an associate professor at NYIT College of Osteopathic Medicine in the OMM department, as well as the director of the Osteopathic Medicine Center.
And I'm Kim Wolf. I'm an osteopathic physician as well. I'm a pediatrician by training, but my practice is exclusively pediatric osteopathic manipulative treatment, or OMT, at this time. I'm a professor in the OMM department at Touro University, California. However, live in San Diego and am participating as the principal investigator for the opt-in study, which is a study looking at plagiocephaly and OMT, and also do a lot of work with Osteopathies Promised to Children and the Osteopathic Center for Children, which are Viola Fryman's nonprofit organizations down here.
I have a couple of questions for you, Kim, before we go any further. So first of all, I'm a gastroenterologist, so I actually saw plagiocephaly on your conference, and I Googled it. So, but for everybody else, can you just tell us what plagiocephaly is and what OMM has, which it seems pretty well connected, plagiocephaly and OMM?
Plagiocephaly is the asymmetry and often flattening of an infant's head. The full name is deformational or positional plagiocephaly. So the infant skull is in 30 pieces at birth, and oftentimes they have a torticollis, or they're spending significant amounts of time sleeping on their back, or things like that, that encourages that asymmetric shift in their skull. Why this is really important for OMT is when I think about these patients osteopathically, there's not just a shift posteriorly, and the posterior shift is what's often most thought about when people look at it, that it cosmetically doesn't look appealing, or they're worried about asymmetry in the long run. But functionally, when you have that shift posteriorly, you have that shift in everything anterior to it. So it misaligns temporal bones, it misaligns mandible, maxilla, it misaligns your mandible in a developing infant. So it's going to change dentition down the line. It's perhaps going to change vision down the line if you have asymmetry of the orbits, which are 7 separate bones in each orbit. It alters your sinus drainage and your middle ear drainage, again, if any of those are shifted. So for me, it's much more functional. The recommended treatment for plagiocephaly is mostly repositioning, so lots of tummy time and stretching and those types of activities. However, many people think about these infants as the helmet babies. And we like to think that we're an alternative to the helmets because we address not only the cosmetic posterior aspect of the head, but the whole face as well, the rest of the body, the torticollis. And so lots of other benefits there.
Viola Fryman, I remember her being a famous DO. Can you tell us a little bit about why the center's named after her and who she was?
So Viola Fryman was a student of Sutherland, who was the founder of cranial osteopathy. And she did a whole lot of cranial osteopathy, but she also was really known as one of the pioneers for pediatric osteopathy. She's got a whole extensive career. She founded two nonprofits, Osteopathy's Promise to Children and the Osteopathic Center for Children. The Osteopathic Center for Children was initially more clinical medicine focused, whereas Osteopathy's Promise to Children more focused on the research side and the education side, so CME. Today, those lines are a little bit more blurred just due to different structures within the organizations, but overall supporting pediatric osteopathic medicine from the research side, the continuing education side, and the clinical practice side.
Can you tell us how the two of you know each other, how you came up with the idea for Cork, and then what is Cork? Or explain to us what it is.
Kim and I worked together at Touro, California, and we initially were roommates in the office. We were office mates. And then as things sort of shifted, I ended up stepping into the chair position and Kim was my vice chair. And so during that time, we started to get much closer and had already started to develop a friendship. And then the pandemic happened. And during the pandemic, we were in charge of turning an entire curriculum at a medical school remote in the midst of so much fear and angst within a week. And so we very quickly became very good friends and realized that this was a friendship for life for sure, and that we worked very well together. And so from there, we continued to just foster not only a professional, but a personal relationship as well. And as we continued to go on along this journey together, we continued to feel frustrated at just the lack of conferences that were available to us that really went into good, high quality osteopathic research. And we were seeing OMM research being done at different institutions, also in different countries, that we thought was really valuable and really needed to be highlighted, but then wasn't really being highlighted at the different conferences that we were going to. And so we also both are the type of people who are like, okay, if this doesn't exist, well, let's create it. And so that was really where Cork grew from. And so we had been talking about it for probably a year or so, but then at March 2022. And so last summer, we sat down together and we said, okay, if we're going to do this, let's start planning it now and let's make it happen, because we don't want to keep pushing it off. And Kim is a pediatrician, so she loves to come up with fun names because that's a very pediatrician thing to do. And so we said, well, if we come up with a fun name, then people will remember it. They might not remember what it stands for, but they'll remember what it is. And so we came up with the Conference on Osteopathic Research and Knowledge, which is Cork, right? We also both love wine. So we were like, it seems perfect. And everyone remembers it. And so that was really where this started. And it grew into something even bigger than we anticipated, because when we brought it back to the team at NYIT-COM, which was helping us plan, they started asking us, well, have you gotten sponsorship? So they really kind of opened our eyes to the breadth of what we could do with this conference.
Some of why we founded it was very selfish reasons. We both stepped into roles where we were doing more research, and a lot of it was figuring out what we were doing on our own, because we weren't connected to people who were doing what we were doing. And we were having to use our networks to ask around and find those people and make those connections. And really what we've been able to do with Cork was put all of those people in the same room, and it was exhilarating.
Right.
To have all the people who are truly doing osteopathic, specifically OMT research, there with you, because there's a lot of conferences focused on scientific research and medical research, but that group of individuals does not have the challenges that we face with osteopathic research, as far as what to do about the sham question. How do we capture what we're doing more objectively? How do we deal with lesser funding? How do we deal with smaller numbers of us doing it, the subjective nature of OMT and those results? And then there's those who are in clinical practice with OMT who weren't looking at that side of it. And so again, we were having a hard time finding the people who were doing exactly what we were doing. And that's what Cork allowed us to create. So we did lectures from a lot of people who are doing amazing research at this time. And we really wanted it to be an update on current projects rather than a focus on past projects. We then did breakout sessions that allowed people to interact and figure out, how do I write a manuscript? How do I seek funding? How do I design an OMT protocol? How do I actually implement a study? What other protocols and procedures do I need to think about? We had one on ethics and morals. We had one on looking at integrating technology and biomarkers and bench research and collaborating. So allowing for really that more personal relationship. And then, of course, because it's an OMT conference, we really wanted to have the hands-on piece. And so on both days of our conference, we had OMT workshops and different options for attending those. We also had panel discussions. We had an amazing happy hour and on Friday night called Distilling with Still to welcome everybody and fit our Cork theme. And then we had an amazing cocktail reception on Saturday evening, which happened to coincide with the 150th birthday of flinging the banner of osteopathy to the breeze. So that was perfect time. And we had a great celebration. We had former President Dr. Ira Manka there to help us celebrate. It really it was such a wonderful event. The other piece of it that was incredible was the involvement of students and a few residents. Having that next generation of osteopathic physicians and ultimately osteopathic researchers there was so exciting. And their excitement was really palpable and motivating and inspiring to keep doing what we're doing and knowing that this is something they're hungry for. They want that different level of accountability. That's what they're seeing and responding to out in the medical literature. And they want to see it from their profession too.
It's interesting to me that, just as an example, I'm giving a lecture on reflux at OMED, and I was reviewing the reflux guidelines. And now the cardiologists are a little bit different. They have evidence for everything. GI were not so much. And all of the guidelines, the evidence was level 4, not good. It was basically just people's opinions. Everything in the GI guidelines for reflux is not good evidence. That's what it says in the guidelines. So it's a bunch of guys sitting in a room and this is what they think. Now, when you talk about OMM, especially with MDs, a lot of times they'll say, well, there's really not enough scientific evidence. But you know what? I'm treating reflux all day long based on no evidence. Right. Do you think that those comments are unfair? And do you think that OMM is scrutinized more and MDs or conventionally practicing doctors are a little too high on the fact that everything they do has reflux and probably most of it doesn't?
Yes, I absolutely do. To address this, I've given several grand rounds at children's hospitals around the country on what is osteopathic medicine, what's OMT, and this is always one of the questions. So I have it front and center in my lecture. And I talk about the challenges that I listed earlier that we face, which is part of why the gap exists. But also, before doing that, I define evidence-based medicine. This term that has been essentially boiled down to, you have to have a randomized controlled trial, you have to have systematic reviews, meta-analyses, all of that, so minimally defines most of medicine and minimally fits it. And especially in the field of pediatrics, because of the limitations on research and the ethics behind it, almost none of what we do in pediatrics is actually well studied in that sense. But the original definition, it was defined in the early 90s as consisting of patients' values and preferences, along with the external evidence, meaning the studies, and then clinical judgment, and really taking in those 3 tiers. I do think we are unfairly scrutinized. I think a lot of it has to do with the fact that for whatever reason, when DOs talk about medication or a surgical referral, we're not questioned. We're respected as physicians, but when OMT is the recommendation, for some reason, we are put into a different category and scrutinized very, very differently. And I think not viewed as physicians anymore with that recommendation. We're viewed as manual medicine practitioners, which we are not. We are physicians who are practicing evidence-based medicine. We have the anatomy training, we have the physiology training, the pathology training. And to us, when we're manipulating, it is very different because of that level.
The whole pharmaceuticals and stuff has such a big draw in the medical profession. And so I think that's a part of it. There's profit for a lot of those things. Oh man, the profit really is in the practitioner who's doing it. That definitely plays into it a bit. I also think it's just in society, we've moved from macro to micro. If you went back and you talked to AT Still 100 plus years ago and you said, hey, there's this mechanical thing that's happening in my body and it's creating these symptoms, most people would look at you and be like, oh, that makes sense. And if you correct it, the symptoms go away. However, with the advent of our knowledge around pharmaceuticals, bugs and drugs, right? We got so granular in that and so microscopic that now that makes sense to people. If you went back 100 years and said you're going to take a pill to get rid of your reflux, people would probably be like, what are you talking about, right? That didn't make sense. But that makes sense to everybody now because of the way that we've moved medicine. And so now the macro is harder for people to grasp. It's harder for people to grasp that, oh, wait, when I have reflux, it causes changes in my spine because that's where the nerves to the stomach are. I have a patient that every time I work on her upper thoracic region, she starts belching and she looks at me and all of my students, she says, I'm so sorry. This is about to happen because there's a relationship between her spine and her stomach. But I think as a society, we've gotten away from that way of thinking. And so it's a little bit difficult to bring us back there.
There's really powerful looking at Louisa Burns' research, Hicks, Patterson, Denslow, and their work is actually incredible looking at those viscerosomatic levels and the change they got in tissue. But I think we don't talk about them as much because they did animal research that today would be viewed as less humane. But the actual work is really profound and impressive and hard to deny what you're seeing. And when I'm practicing, that's what I have in the back of my mind is knowing that anatomy and that physiology and what's actually happening at that granular tissue level.
And if just to reiterate your point, maybe you can comment a little further. I always talk to patients also about complementary or alternative therapies that they'll say, is this any good? Does this work? And I'll say, listen, pharmaceutical company is going to put $1 billion or what have you into research on a chemotherapy or on whatever medication because they're going to make profit afterward, as you were stating, Jordan. If you're talking about probiotics, there's no probiotic company that's going to make a big profit off of the probiotics. So there's no one to fund that clinical research. It doesn't mean that it doesn't work, but I think an intelligent doctor needs to take a step back before they start judging things with less evidence, because something with more evidence may just mean that it's more profitable to a company.
The other thing that drives that a bit too is insurance reimbursement. So things that are reimbursed by insurances become more popular because physicians can make a living. It's been more difficult to get reimbursement. And so the fall off of people who use OMM, it's become less mainstream for that reason. When patients find me, finally, they'll often be like, how do more of you not do this? And that's the question we get. We're just not that well known in this country. Europe is very different.
I reviewed the itinerary for Cork. It looks like when you're talking about research, there's 3 categories. There's basic science, there's clinical, and then I'd call it academic. Maybe you're doing an MRI or you're doing some sort of functional test that wouldn't have, you're just doing a clinical trial. Can you talk to us a little bit, first of all, the basic science? I know there was some mention of doing work on rats or things like this. Like that seems so crazy to me. So I'd love to hear a little bit about what that research looks like and talk to us about what type of people are doing clinical and what the academic centers are looking at. And as I know you mentioned objective data, what objective endpoints you would look at other than just I feel better or doing a survey or something along those lines.
Right. There were sort of 3 things, but I think for me, I come down really 2. One of them is mechanism and the other one is outcomes. And those are the things that I think we're all trying to determine. We need studies, very clinically oriented studies that are looking at outcomes. And then we need studies that are looking at mechanism. And the mechanism is where we get into both the animal and more academic. And so when we think about the rodent-based research, there are only a few people that are currently doing rodent-based OMM research and publishing on it. If they're not publishing, we just don't know about them. We had Dr. Hodge, who had done a lot of research looking at the lymphatic system in rodents. That was really profound and still is, although I think a lot of her publications have been historic and she's moved into a more leadership role, but she is really groundbreaking in that for us. And she's a PhD who works at an osteopathic medical school. And then we have Dr. G, who is an NYIT-COM faculty member down in Arkansas. And she's doing rodent-based research with migraines. Her background is all migraine headaches in rats. And then they've added in the component of OMT on the rodents. They've looked at one, whether it's able to prevent headaches from happening or whether it's able to abort headaches from happening in these rodents. And they've gotten such great results. They actually are an NIH funded. So her next fix, so it's actually going to be looking at the lymphatics, looking at the different aspects of the central nervous system and how OMT is able to prevent and abort these migraine headaches. And then I've also been doing OMT on rodents. We've been looking at the effects of OMT on specifically diabetes. So we've looked at, or we are looking currently at cortisol and some other markers, heart rate variability. So looking at the role of OMT in augmenting the autonomic nervous system and impacting diabetes. So that was from the court conference, that was the main group of us that are doing bench work or biomedical science work or rodent-based work.
Dr.
Yes.
Hope Toby is doing phenomenal research. They're looking at OMT on rodents with Alzheimer's, and they've shown improved memory, improved processing time. On sacrificing them, they've noticed not only decreased polymer plaques and increased monomer, but actually increased aquaporin channels after OMT. And then they've also noticed, I believe it's epigenetic changes when they actually sequenced the DNA in these animals after receiving OMT. So really profound and powerful research in the field of rodent osteopathic manipulation.
And she's also NIH funded, which is a big deal because very little of the NIH funding go to osteopathic medical schools in general, much less OMT research. So when you have a couple of studies like this that are NIH funded, it's a big deal.
The journal article, it was published in the JOM almost 10 years ago. They did an article looking at barriers to osteopathic research, and one of them was the funding. Allopathic institutions outfunded us 800 to 1 on that federal level. A big deficit that we're making up.
So Jordan, can you go further in that first category, I assume with functional MRI, and can you talk to us about those type of studies that are being done or do you think should be done?
There is so much exciting things happening here, especially since NYIT-COM is opening a new research facility that's going to have an fMRI machine. And that's kind of how this relationship with Dr. Ceratelli and his team in Italy that are doing fMRI and OMM research. They're one of the only people, if not the only people in the world that are publishing on it currently. And they're looking at different aspects of OMM and not only structural aspects of the brain, but functional aspects of the brain. Published pretty extensively on this and currently are in the process of working on about 4 or 5 new manuscripts on their new findings, which they're also looking at thermograms, which look at, it's essentially looking at heat in different aspects of the face that are correlate with the autonomic nervous system. So they're able to look at how OMT is shifting these thermograms and shifting the autonomic nervous system. Lots of really cool research that's cutting edge. I feel like our tools have caught up to our fingers. So the human palpation is so incredibly refined that it's been hard up until now to have a tool that actually can have that same level of refinement to be able to do good objective measures of what we're doing.
One of the coolest things that I think about when talk about the technology catching up to our fingers is coming from outside of our profession. Some of the work that NASA's done looking at skull mobility. There's a group out of Japan that's done functional MRI and different MRI imaging that magnifies the flow of CSF. And they found that we're taught that classic flow of CSF with the arrows pointing here, and it looks like a nice continuous flow, but it really on MRI, they're capturing that it pulsates. Very consistent with what we've described for 150 years now of more of that PRN, that primary respiratory mechanism.
With this new MRI, I think we're actually going to be able to measure lymphatics, which is pretty incredible to think about because until about 10 years ago, it was thought that there was no lymphatic system within the central nervous system. And now every month I look into these papers and more is being discovered about how this drainage system is. And Dr. G down in Arkansas is actually currently she's doing it with mouse models, but she's injecting into the CNS so that she can actually model out the lymphatic system. So really exciting, new, innovative research because we now have the tools and the technology to be able to measure these things.
Kim, just to ask you about cranial rhythmic impulse. And I remember I haven't done any of these things since I'm a medical student, but I could definitely feel it at some point training. And if you look in allopathic slash MD textbook, it doesn't talk about any of these things. So do you think these studies with these new MRIs are going to actually just prove what DOs have been saying about this for 100 years?
I do. I think we're going to find it. I don't know exactly which study is going to pinpoint it exactly because there's, again, still challenges to figuring this out. And it's such a fine level of palpation that, again, which tool is going to be able to capture this. The lectures on CRI were given by Kyle Henderson, who's out of Chicago College of Osteopathic Medicine, and it was fascinating. He's a PhD, really devoted to the field of osteopathy and promoting osteopathic research. He's the current chair of the Louisa Burns Osteopathic Research Committee for the American Academy of Osteopathy. But he was talking about all the different ways that they've explored it. And one of the most recent one, again, talking about different objective measures, is they're using Eulerian cameras, which are cameras that were originally designed for military grade espionage that captures just very subtle changes. And so, for example, they took pictures of face on a pillow and showed that when you capture these still images and break them down on a granular level, you can capture blood flow changes, but also there seemed to be another signal happening in between a heart rate pulse and that color change. So just trying all these different really creative ways of exploring how do we find this? How do we document this? And there's a lot of research that has captured these other signals, but still elucidating that mechanism, elucidating exactly what we're feeling, and also validating the inter-rater reliability is really important. Outside of the field, there's this level of confidence about it. We've got a long way to go still, but there are definitely multiple fronts that this is being explored on, and it's really exciting to see.
So getting into the clinical part, I saw that there were a lot of lectures on how to set up clinical research. We've had Gerard Balthazar on, who I saw lectured. He's great. But if he wanted to do a study in the ICU, as far as going by strict standards, you would need a control group to show that this group's doing better than the control group, and you'd have to do something to the control group. And I know, Kim, you mentioned talking about sham manipulation or something as a comparison in the control group. You can't just do nothing. So can you talk to us a little bit about what does sham OMM look like? What is that? Number one. Number two, you also mentioned some ethical issues. Can you talk to us about the ethical issues that come up? Because I don't know what that would be.
This is a lot of what I've worked on in my career is more the clinical side of things and looking at outcomes. The sham OMT continues to be a struggle because ideally, again, you have that control group. However, there's lots of ways to get that control group. You can do population matched controls. You can do historical comparison of results. So there are some people who have done chart review on age match controls in retrospect and said, here are the outcomes from these groups. Here are the outcomes from who I treated.
For the listeners, we always talk about the placebo effect, I guess, which is the main issue. So placebo effect is so potent that maybe you're the doctor, you're touching the patient and you're telling them this is going to help you. And there are obviously a million studies showing that that doctor effect is a placebo effect, but there is healing just to the doctor telling you you're going to get better and treating you. So that's the question. How much of this is just the doctor treating the patient and how much of it is the actual OMT? So how do you tease that out?
So the placebo effect is not just a placebo effect. And there's a lot of studies elucidating that the placebo effect actually causes physiologic changes. There even seem to be some genetic predisposition as to who benefits more from that placebo effect. And so that's really important to take into consideration. The other challenge with sham is, again, if you do just a light touch, first of all, if that's done by a DO, cranial is light touch. Myofascial release is light touch. And most of us who are using this in our career, the second I put my hands on someone, I'm already tapping into things and getting information from their body. And whether I like it or not, often treating unintentionally, it's just sort of what my hands are trained to do. And so having us do that sham is really hard. But then there's also just the power of touch. We know it has its own benefit that's been well documented and well studied. And so if you're touching a patient, even if you're not a DO, how do you tease out what's that benefit versus what's happening with OMT? Then there's the sham, such as ultrasound, that has been used in OMT studies, but that has a huge placebo effect because people see a device, a machine, and they think, oh, of course, this is doing something to me. So that has more of that placebo impact as well. So a lot of what's happening is comparing to age-matched controls. Our study where we're doing the plagiocephaly, what we did is a randomized crossover trial. So they're serving as their own control. And this also goes into one of the ethical issues of, if I feel that OMT is so beneficial to these patients with plagiocephaly, and I have a very narrow window in which I can treat them, because the older they get, the more those sutures are fusing and the less benefit they can have from this modality, how do I not offer to? So what we did with the opt-in study is they're randomized to either treatment or standard of care. And their treatment group is OMT, and they get 8 weeks of OMT with 1 visit per week. And then they get 8 weeks in the standard of care group, which is just repositioning. And they're given standardized instructions on how to do that repositioning. They have measurements at the beginning and the end of their 8 weeks, as opposed to those in the OMT group who are getting measurements not only weekly at their OMT visits, but actually pre and post OMT, but talking about objective measurements. And so that's our sham, our control group, is they're serving as their own control. So we're seeing what happens when we treat them earlier versus when we treat them later. What happens when they're in the repositioning group first versus when they're in the OMT group first, and vice versa, and comparing that. I also did a latch study, so looking at babies who were having difficulty breastfeeding, and we treated patients in the newborn nursery. And so the way that we did it was we blinded the nurses and the lactation consultants and the parents, who were all actively assessing the child's latch, by taking the children into the newborn nursery, and they just stayed with us for 10 minutes, and we either treated them or we didn't. But those who actually were performing the assessment were blinded. I also did research looking at clinical outcomes on treating children with autism spectrum disorder, partnering with UCSF. And what we ran into is, literally, when I submitted the manuscript to a journal that had a focus on autism outside of the osteopathic profession, one of the pieces of feedback we received was, how do you know that they didn't like the personality of the treater? And we're talking about many of my patients being nonverbal, more impacted with their functioning. And so again, really interesting that that's what they went to, that was more powerful than the actual intervention itself was. But again, this is what we're up against. We have docs out there working with more vulnerable populations, such as Alice Chen, who's at UCSD treating in the ICU. She's treating literally post-op craniotomy patients. She's treating post-organ transplant patients. We have Jennifer Belsky and Amber Brown, who are treating pediatric hem-onc patients. And I think a lot of these studies looking at the safety as well is huge in these, and bodes to, even if we don't have the dramatic studies proving benefit yet, we do know that what we're doing is safe, and that's been proven time and time again.
Ian, you had already mentioned, so much of what you do is expert opinion, and it's acceptable. Dr. Brown and Dr. Belsky, who are hem-onc, pediatric population, they're going in and they're giving pain reduction in constipation. They're giving these symptomatic reliefs that the patients are then saying, yes, this helped me. I want to have this in the future. That is of value. And I think it's just reminding ourselves that that is still a value, even if you don't have a randomized controlled trial of patients who are suffering from constipation, from chemotherapy in the pediatric unit. That doesn't mean that the work that they're doing isn't still really powerful. And so I think it's just reminding ourselves that we are getting more randomized controlled trials. We are trying to get around sham the best we can. I will say the objective measures help with sham. All of the MRI studies that are coming out of Italy are sham. They all have OMT and sham. So we're finding more objective ways to get around sham. And then we need to start looking towards procedural-based research projects because we are a procedure. You don't do sham appendectomies. So we need to start modeling our research after procedural-based research models.
It looked like there were a large section, how to set up research, what does the research look like? There were OMM labs where people could practice techniques. And then there were some special guest lecturers. So I'm just curious about Dr. Hollis, who is there. And then there was a few-day course from European DO named Dr. Perrin. Can you tell me a little bit about how you chose who your experts were going to be and what specifically they brought to the conference?
We invited Hollis King to be our inaugural Cork keynote speaker. And we invited Hollis because he, the pillar in the field who has been involved with osteopathic research and the advancement of the field for decades. He's worked with all of the big people when we think of osteopathic research, including Lisa Hodge and John Leecherdone, Brian Dagenhart, Viola Fryman. I mean, he worked with all of them. He helped get a lot of these institutions and these organizations up and running. And so he's just so critical to the field. He also has for years been very intimately following the osteopathic research and delivers lectures on the state of osteopathic research. And he can tell you all of the publications that are out there and what do you think about Parkinson's? And he can tell you all the studies on OMT and Parkinson's and recite that back to you. And so he's just such a wealth of information. And we were so privileged and honored to have him be that first keynote speaker who's actively able to give the history of where we've come from in this profession and lay that foundation, but also give us the call to action to move forward and tell us what he's seeing on the horizon and about his current projects that he's doing.
And as Kim and I normally do, we went big. Dr. Perrin is a UK-based osteopath. Osteopaths in Europe and other countries are not fully licensed physicians. Their training is in the more traditional osteopathic hands-on assessment and treatments. Dr. Perrin then went on to do a PhD. So he's a DO PhD. And his research over the last 35 years has really been committed to chronic fatigue syndrome. So 35 years ago, if somebody came to you with chronic fatigue syndrome, you would think they were crazy. It wasn't really an acceptable diagnosis. People thought people had depression. And over the last 35 years, we've come to know that chronic fatigue syndrome is real. And it has to do with a myriad of different symptoms, all related most likely to the lymphatic system. And so Dr. Perrin's research has really been into chronic fatigue syndrome and the comorbidities of chronic fatigue syndrome. So dysautonomia, POTS, different types of GI symptoms, sleep disorders. And now we're seeing similar symptoms with our post-COVID syndrome or our long COVID patients. And so his research has really been designed to study this. And he's developed a technique that is in many ways a lymphatic drainage technique, a lymphatic massage technique with some additional cranial involved that has shown in studies to be effective at treating and even curing chronic fatigue syndrome, which he now is doing a big research project with the National Health System in the UK to look at his techniques with post-COVID syndrome or long COVID, and he's getting exceptional results. And so I had brought him over last year based off of the recommendation of one of my students who saw him lecture and was so impressed with his science and his research. He did a session with us and trained a bunch of us. And because having this training, I started getting people finding me on Reddit and all these different websites because I knew how to do the Perrin technique. So it became such an important part of my practice, especially in the post-COVID world, that I decided to bring him back so that he could do this training again. And it will likely be an annual training that we do because of how invaluable and what a resource he is.
So Osteopathy's Promise to Children hosted that pre-court course, which was called Beyond Boundaries, Osteopathic Care of the Preterm Infant. And this focused on Dr. Certelli's work with preterm infants in the NICU. So Dr. Certelli is also a DO PhD in neuroscience, and the work he's done in the NICU is just phenomenal. As a pediatrician, I've been a fan of his work for years. He's done a number of studies in the NICU, and the most compelling is that he's a decreased length of stay for the infants that receive OMT. The cost savings of that for the American healthcare system would be incredible. So huge potential there. The other piece of what he shared with us in that course is his development of something called the NAME Index, which is a 90-second assessment of these preterm infants in the NICU that's based on palpation, but they've shown inter-rater reliability with not only the osteopaths performing it, but other team members like nurses, MD, physicians, etc., and been able to validate it as a tool of clinical status. This is really significant because it is the only assessment of the infant in the NICU currently that uses palpation. All of the rest of it is really dependent on vitals and having all those tools, but also many of the next shortest one is 30 minutes, and some of them are even longer, assess that clinical status. And they've been able to show that with this 90-second palpation and training their teams, they've been able to predict outcomes, especially related to respiratory decline. So powerful, not only directly related to actual performance of OMT on these infants, but in ways that palpation can be utilized in the NICU population as well for other important outcomes. That course is available through Osteopathy's Promise to Children on demand.
I actually met with Francesco today and our team at NYIT-COM because we're in the process of trying to build the largest repository and database OMM research. So stay tuned.
And Dr. Cheritelli will be making an appearance at Cork 2025.
Just today, Cork 2025.
Conference sounded amazing. We look forward to talking to you again in 2025 for the next conference. Thank you both for putting Cork on the map. Thank you for spending time with us and telling us all about it today.
Cork 2025, last weekend in April 26th and 27th. So put it on the calendar in Long Island.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there is someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tianyu Shea. Thank you guys so much for listening to Do or Do Not.